A very good, warm good afternoon, everyone. Hi, I'm Dr. Charvi, Program Officer in Smile Train India. And Smile Train is the world's leading cleft charity, providing the cleft surgery and comprehensive cleft care to children in need throughout India and world. We use the teach a man to fish model and we focus on training and empowering local doctors to provide comprehensive cleft care in their communities. Smile Train and Foxy have come together to bridge yet another gap of cleft lip and palate. And experts from both Smile Train and Foxy have come together, the fetal medicine experts, the gynecologists, the maxillofacial surgeons, plastic surgeons, they've come together and they have created a joint protocol for diagnosis of cleft lip and palate. And as in continuation with our joint initiative, we have started this webinar series of cleft lip and palate, and I welcome you all in the first webinar of the series. Moving forward, I would like to introduce Dr. Amina, who is also the speaker and convener of the series. He was the former Joint Secretary of Foxy in 2019, and he is currently a consultant obstetrician and gynecologist at Purandare Hospital and KJ Somaya Medical College. Over to you, Dr. Amina.
Thank you so much for those kind words, and indeed gives me great pleasure to convene this very important webinar, the first in his series. First of all, I'd like to congratulate and commend the efforts put by Dr. Pai very passionately to strive for cleft lip and cleft palate. It's a diagnosable defect, it's a correctable defect, and to gain more insight into its prevalence, prevention, as well as its diagnosis and final management, we have a group of experts. My colleague Dr. Pooja Lodha from Pune and Dr. Krishnamurthy are well-renowned pediatric surgeon. I'd also like to welcome, in addition to Dr. Rishikesh Pai, our Foxy president, Dr. Madhuri Patel, our Secretary General of Foxy, who through her vast administrative and academic experience has always guided us to ensure that we deliver babies with the best outcomes. I'd like to invite and formally introduce Dr. Rishikesh Pai. Dr. Rishikesh Pai, can we have his CV, please? Dr. Rishikesh Pai is the president of Foxy. He's a very well-known figure, not only in India, but all over the world. And he has always striven for the betterment of women's health. Right from before conception, he's a leading IVF specialist known worldwide, but also through his administration and leadership at the Manyata program to ensure that quality care is provided during pregnancy and childbirth. Dr. Pai is the medical director of the Bloom IVF group, which is a leading group and has been awarded with various reputed awards. And Dr. Pai is now championing Foxy's Badlav campaign. So we'd like to hear from Dr. Pai what his vision for preventing birth defects and to ensure the best of babies is. Over to you, Dr. Pai. A warm welcome.
Thank you. Thank you, Amaya. I would like to thank the Foxy and the Smile Train, as well as Science Integra and all of you for conducting this very important program. And I would like to first of all recognize senior people who are there. Dr. Madhuri Patel, our Secretary General, who is found time and to come for this program. Then we have got Dr. Krishnamurthy, who is a leading oral and maxillofacial surgeon. Thank you, Dr. Krishnamurthy, for doing this fantastic work on the preventive aspects of cleft lip and cleft palate. And then we have the today's speakers who are going to be there, Dr. Krishnamurthy himself, and then Dr. Amaya Purandare, who, as you all know, is a very active Foxy member, a leading consultant gynecologist, and even attached to multiple hospitals in the city of Mumbai, and Dr. Pooja Lodha, who's a very well-known fetal medicine specialist. She's also a gynecologist from the city of Pune. So we have a fantastic team that is going to teach you today about various aspects of the cleft lip, cleft palate. I would like to say that malformations are due to multifactorial reasons. You may have chromosomal defects, which can lead to some kind of malformation in the fetus. You may have genetic defects, and chromosome, of course, you can do a karyotyping. And for genetic defect, nowadays, a lot of new screening modalities are available by whole genome sequencing can be done on both the husband and the wife, and then we have infections that can contribute to some kind of malformation and environmental factors like radiation, chemical exposure. There's a lot of contamination in the food that we eat today. Lead, mercury contamination is very high. And of course, we know that nutritional deficiencies like folic acid deficiency and other micronutrients also can contribute to these kind of problems. And so we must try to look at the etiologies as well as how to prevent these problems. And if we get those problems, how to treat them. So I'm sure that today's seminar and many more to follow will educate all the most important people who in this line, which are the healthcare workers. The point of contact is very important, and educate them so that they can implement it more effectively in their practice. So without taking much of your time, I would like to congratulate all of you again, and we look forward to a very enriching experience, both from the point of view of knowledge as well as from the point of skill enhancement. Thank you very much for calling me for this. Thank you.
Sir, just a few words. When we had talked about how this program would be and what your ideas were, you had said it is in sync with your Badlav campaign. So could you tell us how you envision the Badlav campaign and how it is relevant to things like cleft lip and cleft palate?
No. So the Badlav campaign is basically made up of 3 parts. The Ekikaran, then we have got the second part, which is the Samanta part, and the third part is technology. So we have the Ekikaran is, as I told you, that when we are going to do advocacy and awareness in the community, we are going to do a 360 targeting. So in 10 minutes time, we should be telling all our patients whatever they will come across in their life from beginning to end and what is available. So during the targeting, when they're sitting in your consulting room, and this is good, you reminded me, because I have to finish that the cartoon which which we had made for the Yatra, and that cartoon has to be supplied to all the people. So maybe Science Integra can take that forward. And then the second part is the Samanta, which is that this technology, this knowledge should be available to the rich and the poor equally. Equity or equality, or equity as you call it. In Hindi, Samanta is equality, but equity is Samta. So this is very important also, that there should be gender equality, there should be equality of the races, equality of the caste, equality of education, poor and rich. All that equity should be factored in. So this knowledge can be given to everyone, and this treatment can be accessible to everyone. And third part is technology, Takniki, which is the third part of my philosophy. And that is that using technology, modern technology, artificial intelligence, whatever way you enhance this treatment modalities, not only in terms of getting the treatment is not doing treatment. Treatment is to go to the community and pull out the people who need the treatment. It's not just doing people who walk into it, because there is what we found in the Yatra, which we did, or in the Pratibandh, which was our cancer screening program. What we found was that with the people, we did 4,200 patients all over India, and we found that majority of them had done pap smear for the first time. That means they don't come for checkup anyway. So we have to go after them. We have to not wait for them to come. We have to go in the community and pull them out. So Dr. Krishnamurthy, I'm sure there are hundreds and thousands of cleft lips and cleft palate that are sitting in their houses. They don't know what to do. They don't know where to go and who to go to. And that is what we will need to do. You understand? Because I feel that the problem is not that easy, that's not that small. Problem is large, but our Indian people, they are tolerant. They live with it. They have learned to live with it. They don't have that in them to fight it. And we need to tell them about it, that you can fight it. We can treat you. You can come to us. You don't need to have money. They may not be knowing also what is Ayushman Bharat also. That our great Prime Minister, Mr. Modi ji, has created this new system where they can do free of charge. So we have to tell them all this. So awareness and advocacy is very important.
Thank you, Dr. Pai. I think it's very relevant and very visionary, the Badlav campaign of yours, and especially to every aspect of women's health, not just pregnancy. Now, I think over to you. Before we go on to actually beginning, we have Dr. Madhuri Patel with us. Dr. Madhuri Patel is a very well-known teacher, a highly reputed academician. She's the General Secretary of FOGSI. She's associated with very busy hospitals in the city of Mumbai, like the Wadia Hospital, Masina Hospital, St. Elizabeth Hospital, etc. Dr. Madhuri Patel has been an ex-professor and HOD with the MUHS and also been a professor at the GMC Mumbai. She's also associated with the FOGSI Journal, and at present is the joint associated editor. But overall, she's a champion for women's health and improving pregnancy outcomes. So thank you so much, Dr. Patel, for gracing this occasion, and we are looking forward to hearing from you on this very important topic.
Dear Amaya, thank you very much for your kind and warm words. Respected our President FOGSI, Dr. Rishikesh Pai, he is most dynamic as well as visionary. He talked about his vision. He talked about Yatra. He talked about Badlav, but I have experienced it. So, I must say the Yatra was most successful, where we used to go to the centers, not the society, where morning we used to have a community program. What Dr. Rishikesh said, that people have gone for first time for the pap smear. So we used to make aware them about the cervical cancer and the breast cancer and other diseases. At the same time, is to screen the patient. Then evening is to have a meeting with the journalist, press conference. So even the press people are very important to us to make our community to aware about the diseases which we can prevent and which we can treat. And in the evening, we used to have again, CME with the local society. So this Yatra was very, very successful. And now the Badlav, which is also taking a shape, and it is going to be very, very successful. And Rishikesh is not having these two projects, but there are many projects. We think about the maternal mortality reduction. At the same time, we think about the NCD, prevention of the preventive oncology and elimination of the cervical cancer. But now we are also with the babies. That is very, very important thing. Just before starting this webinar, I was, talking to Dr. Krishnamurthy that what we were seeing in the residency period, the cleft palate and cleft lip were very, very, common. But now, we see, but not so many. So he said, of course, we don't have studies on that we can compare. But what he told me, which is very, very, true, that in Australia, they have done some survey and they found the abortion rate, because we can diagnose with the imaging during the prenatal, during the antenatal period. So chances of abortion rate is high and the chances of live baby are low. But still, whatever it is, because whatever babies are there, we have to treat them because they have a feeding problem, they have other problem. In the beginning, they have to go through multiple surgery depending upon the cleft palate and cleft lip, depending upon that, multiple surgery, other congenital malformation. And of course, everything is fine. Then of course, the baby is always, worried about the cosmetic aspect. Of course, we have a great, Dr. Krishnamurthy, who is a oral and maxillofacial surgery. He, plastic surgeon. They are giving the best result. Pooja is there to talk about the imaging. She's excellent in her work. And Amaya is also going to talk about the prevalence and prevention. So Rishikesh has pointed out what are the causes, but we also say the consanguineous marriage is also one of the causes, and women and all the generation is getting educated. So we hope that we see the less incidence. And secondly, if the baby is born with a cleft palate and cleft lip, we give the best to the babies and the parents. So with this, I congratulate Dr. Rishikesh and Science Integra and our, Smart Smile, right? Smart Tray. that, excellent series you are going to start. Today is the first part of the series, and this will really help our community as well as our doctors, as well as all us, to not only sensitize, but make them aware and implement. So thank you once again for giving me this opportunity.
Thank you, madam, for those encouraging words. I think it means a lot to the morale of this very important project, which is carried out all over India and brings the smile back on many a baby's face. Over to you, Charmi, to proceed with the further talks. Charmi? Do you have the CV slide, or shall I begin?
No, I think you can go ahead, Dr. Ramya. Yeah.
Thank you. So I'll be the first speaker for the day, and I hope you can see the slides clearly. Karvi, can you see the slides clearly?
Yes, sir. You can go ahead.
Yes, we can see the slides. We can see.
Yes.
Thank you. So I'm going to be talking about prevention and prevalence of cleft lip and cleft palate, especially with respect to the Indian scenario. Now, we all know that cleft lip and cleft palate are because of an aberration in the embryology or the development of the young fetus in the intrauterine stage. It arises or begins around the fourth development stage, and the exact locations are determined at which fusion of various facial processes fail to occur. So it's a result of failure of fusion. It is influenced by the time in the embryologic life where some interference with development occurs. We really don't know what exactly triggers it, but obviously it is some deterrent to the normal developmental process. So to understand the embryo pathogenesis, cleft lip is results because of failure of fusion of the frontonasal and maxillary processes. Cleft of varying extent through lip and alveolus and nasal floor occur. There are two types: incomplete cleft, which does not extend through the nasal floor, and the complete cleft, where the alar base and the medial labial element are not connected. On the other hand, cleft palate is the failure of fusion of the palatal cells of the maxillary processes. The cleft of the hard and or soft palate is noted, and hence it is called as cleft palate. I will not go into the deeper understanding of these because Dr. Krishnamurthy will explain to us the anatosurgical correlation as to how these occur and how they can be corrected. To look at the incidence, one must remember that the overall incidence of cleft lip and cleft palate, as published in Gauri Shankar's textbook, is around 1 in 600 to 1 in 800 live births in India, an average of about 1 in 700. Which comes to about 1.42 in 1,000 live births. Isolated cleft palate, on the other hand, occurs approximately in 1 in 2,000 live births. What about the differences in demographics with respect to the global scenario and the Indian scenario? It's more common in Asians, it's intermediate in Caucasians, it's low in Africans, and in Chinese and Japanese, it's somewhere in between. As far as India is concerned, we have about 24.5 million births per year, and the prevalence of clefts is around ranging from 27,000 to 33,000 annually, as per the studies published in the Indian Journal of Plastic Surgery in 2009. What about the breakup of these as compared to the neural tube defects? Friends, neural tube defects are almost 3 times more common as compared to cleft lip and palate. As I said, cleft lip associated with palate is more common than cleft palate alone, as far as Indian estimates are concerned. There are different types, but the simple typical distribution of clefts is that cleft occurs solitarily, it occurs in combination with the palate, or there may be isolated cleft palate. The incidence of this is cleft lip and palate is most common, followed by cleft palate, and cleft lip is only 15% of the cases. Now, I'm going to be talking about the second part of my talk, that is about prevention. Benjamin Franklin, one of the key philosophers of the modern era, said that an ounce of prevention is worth a pound of cure. Probably he meant about public health, even though he was a well-known philosopher and an economist. Friends, to extrapolate what he said, folic acid has a very important role in cleft lip and palate. You know that it's a debilitating condition which causes significant feeding, hearing, speech, and psychological issues. And extensive medical and behavioral interventions are needed to treat them. It indeed results in a considerable amount of economic, psychological, and personal burden on not just the patient, the family, but also the health system. And hence, its prevention is a must. It should be cost-effective and is extremely desirable. How can we prevent cleft lips with folic acid? If folic acid supplements are given in addition to a high folate diet, it results in a marked 75% reduction in cleft lip and palate risk. A significant 67%, that is 2/3, reduction in cleft lip and palate recurrence was also observed in infants whose mothers delivered a previous baby with a orofacial cleft. So not just in primaries, but even those at risk, if folic acid is added, it will definitely reduce the risk of subsequent cleft lip and cleft palate. Hence, as proposed by various epidemiological experts, folic acid supplementation can prevent the occurrence of cleft lip and palate. How much folic acid do we give? As far as Indian women are concerned, the periconceptional period is very important when they come to talk to us about planning their pregnancy. High-dose folic acid supplementation during this period reduces the risk of occurrence of non-syndromic clefts and the recurrence of high-risk cases. The dose that should be used for prevention of recurrence needs to be standardized to 5 mg per as done in neural tube defects, as proposed by Jayarajan et al. In the Indian Journal of Plastic Surgery just a couple of years back. Let's look at the nutritional aspects in preventing cleft lip and palate. Women's nutritional status just before conception and during early pregnancy impacts the outcomes by affecting critical fetal developmental processes during early pregnancy. Folic acid and other micronutrients or vitamins, including vitamin A, B6, may be very important in the etiology of clefts. Mothers of cleft lip and palate children in southern India were 6.5 times more likely to have poor vitamin B12 status, thus emphasizing that in the periconceptual period, the woman's deficiencies should be adequately corrected by supplements or nutrients, most likely a multivitamin combination or strategy. Low maternal B6 measured after pregnancy increases the risk of cleft lip and palate, especially those in which there is low serum folate levels. Low maternal B1 and zinc myoinositol are also associated with an increased risk of oral clefts. The twofold elevated risk of cleft palate was noted with a low intake of riboflavin, magnesium, calcium, vitamin B12, and zinc. The authors concluded that periconceptional nutrient intake is associated with the risk of cleft lip and cleft palate, and we as obstetricians should ensure that the woman has the best nutrient makeup before she embarks on pregnancy. What about if we give these patients this multivitamin? Are there some real-world studies? In these two papers, which the first of which was published in 1982 in the Lancet, and the second one, which is published recently in the Craniofacial Journal, they emphasize that multivitamin use with folic acid reduces the risk by 30 to 50%. A 84% reduction in recurrence of cleft lip and palate in women who receive a multivitamin and 10 mg of folic acid during the 3 months before conception and throughout the first 3 months of pregnancy has been very well noted. Group B vitamins, including folic acid supplementation during pregnancy, therefore, has been shown as an effective preventive strategy as far as cleft lip and palate is concerned. Do we have certain Indian studies to talk about the role of folic acid? In this study, which is published just a year and a half back, a statistically significant protective association was found for folic acid supplementation. Higher levels of dietary folate were associated with a reduced risk of all clefts, be it lip and palate or palate in isolation. And therefore, we must keep in mind that dietary folate is important to reduce the risk. As far as the Indian population is concerned, we have certain recommendations or regimens for women of childbearing age. And this one, which has been published in the Dental Association's paper, says that with women with no history of previous neural tube defect affected pregnancy, you need to give only 400 micrograms. Who've had a previous neural tube, 4,000 micrograms, and other high-risk pregnancies, especially those who are diabetic, who have familial disorders, or even those who have seizures or on anticoagulants, or rather anticonvulsants, have to be given a higher dose. And last but not the least, we have fortified our food with iodine. We have fortified our food with various other preparations. We need to seriously look for fortifying our food with folic acid, and all that we require is 400 micrograms. The Indian Council of Medical Research has proposed that 200 micrograms should be the intake of folate for adult women, taking the current level of intake and prevalence of subclinical deficiency into consideration. Pregnancy and lactation are special periods, should be looked at differently, and therefore an additional 300 and 100 micrograms respectively should be added in these two periods. The Indian Association of Medicine says that women who are capable of becoming pregnant should consume 300 plus 100, that is 400 micrograms of folic acid daily from fortified foods or supplements. Friends, cleft lip and cleft palate can be prevented. We need to emphasize to our patients the role of dietary deficiencies, multivitamins, and folic acid, because we want to ensure that your smile makes your life more beautiful. Thank you so much. So we'll move on to the next talk now, and it gives me great pleasure to invite Dr. Pooja Lodha. Dr. Pooja Lodha is the director of Kangaroo Cradle Fetal Care Clinic. It's a state-of-the-art fetal medicine center in Pune. She's the lead consultant in fetal medicine and fetal therapy. Is also associated with the Ruby Hall and the Bharati Vidyapeeth Medical College, Pune, and is the Southeast Asia ambassador for the International FIGO platform. She's a faculty trainer with MUHS and has also been the recipient of various awards for her significant work done in fetal medicine. Over to Dr. Pooja Lodha, who will be talking to us about imaging for cleft disorders in the fetus.
Thank you, sir, for the kind introduction. At the outset, I'd like to thank President FOGSI, Dr. Hrishikesh Pai, sir, Secretary General, Dr. Madhuri Patel, ma'am, the convener for today's program, Dr. Ameya Purandare, sir. Thank you so much for this opportunity, and thank you for laying an excellent base for this talk. Are the slides visible?
Yeah, Pooja.
Hello, Dr. Ramamurthy, sir. It was great to exchange views with you and learn with you during the Smile Train. Algorithms were being built, And this was actually a lot thanks to Dr. Nandita Palshetkar ma'am as well, because she was also instrumental in linking the Smile Train with Foxy. And so happy to see Rishikesh Pai sir also being so interested in it. And today we are going to talk about imaging in cleft lip and cleft palate. Prevention is the best thing, but the next best thing is diagnosis, because prevention may not always be feasible. And today I will talk on how to diagnose cleft lip and cleft palate. I would like to mention references for my talk. I have basically included the ISWA guidelines, but I would fail in my duty if I do not thank Dr. Lakshmi Ravi Selvaraj, who has been instrumental in introducing a lot of science and very simplistic science and algorithms for the diagnosis of cleft lip and cleft palate. And her work has been recognized and included even in the international guidelines. So it is a proud moment for us Indians. And I would mention at various places the contributions of Dr. Lakshmi Selvaraj as well. So cleft lip and palate is one of the most common congenital malformations of the head neck. And the prevalence, as sir was telling, is 1 in 700 worldwide. Now this prevalence is going to be very different if we look at antenatal diagnosis. And we would also listen to the prevalence from Dr. Krishnamurthy sir, because of all those diagnosed antenatally, unfortunately, very few reach the pediatric surgeon or the maxillofacial surgeon, because in India, the whole perception of perfection is very different still. And if we show them pictures, 3Ds of how their baby would look at birth, a majority of them would still consider at least termination. And then we work hard. We include the pediatric surgeon, the maxillofacial surgeon, the geneticist, and we try to convince them that if this is an isolated defect and if the baby is genetically and otherwise structurally normal, they would do well with help postnatally. At the same time, we need to give them a realistic picture about what could go wrong, especially when there is associated cleft palate. There could be aesthetic and functional problems, including difficulty in feeding, dental problems, abnormal facial growth, speech development, and hearing difficulties. So just telling them that your baby is going to need 2 sets of surgery does not suffice. And hence the counseling and the decision making for the couple, whether they wish to continue this pregnancy or not, will depend on all these aspects. And as fetal medicine specialists, we truly believe that instead of doing all this counseling ourselves, we like to involve an orofacial surgeon, because they are the ones who would be taking care of this baby once the baby is born. And they would be able to give the couple more realistic figures about how their plan of management of the baby postnatally is going to be. So it's a multidisciplinary care like any other problem in antenatal diagnosis. So we call cleft lip and palate one of the commonest surgically correctable and antenatally diagnosable problems. But we need to see that we involve all these disciplines in order to help the couple make a decision. 25% are isolated cleft lip, 25% are isolated cleft palates, and 50% would have cleft lip, cleft palate both. 75% of them are unilateral and 25% are bilateral. The diagnosis of cleft lip is a part of the ISWA guidelines for mid-trimester ultrasound, and therefore we have to diagnose a cleft lip. It's one of the must-diagnosed abnormalities antenatally. But cleft palate so far is not a part of the routine antenatal algorithms and protocols for diagnosis. But we will also see why we should look harder and look for the cleft palate as well. Now, many studies have quoted that the prenatal diagnosis of cleft palate is very low as 0.4 to 2%, which shows that there is no satisfactory ultrasound indicator for cleft palate. And I'm talking about cases where there is isolated cleft palate, because once you diagnose a cleft lip, you would definitely look harder and search for the cleft palate, which makes things easier. But the whole problem arises in the 25% where there is no cleft lip. The baby is otherwise totally fine. There is no history of the previous sibling or the parents having a cleft lip palate. And then there is this high BMI Indian mother where the views are not great and you have an isolated cleft palate. And that makes the diagnosis very, very low. The pickup rate is low. And we would come to why the pickup rate is low and what we can do to improve it. Now, of course, following a basic algorithmic approach is the best thing to do. And I would come to that at the end of this presentation. But behind my slide in the background, you can see how many multiple permutations and combinations of clefts in the orofacial area are possible. So it's not that simple. It's just a cleft lip or a cleft palate. And Dr. Ramamurthy sir would take us through the intricacies of difficulties in managing various kinds of clefts there. So you can see so many combinations are possible. And if you see, this paper dates back to 1919. So it's been 100 years now that we know the types of clefts that exist, and yet our diagnosis for cleft palates has been very, very poor. Ameya sir has beautifully taken us through the anatomy and the embryology for the cleft palate and the cleft lip. But basically, if you just look at this picture, the typical clefts usually, so 90% of the clefts would occur along the lines of fusion. And this also forms the basis for the repair postnatally. When you come to cleft palate diagnosis, the direct visualization of the cleft palate antenatally is very difficult. And therefore, an intact uvula is a surrogate marker. So if you're seeing a uvula, you are almost always sure that the palate is intact. So direct visualization of palate is not feasible antenatally on ultrasound, and therefore we have to get around ticks and trips to see what can we see that is an indirect indicator that the palate is normal. Now, one of the most commonly acceptable classifications that we also report antenatally on ultrasound diagnosis is the Kernahan's classification, and it's actually very simple. If we just see this from 1 to 9, you look at the right lip, the right alveolus, right premaxilla, left lip, left alveolus, left premaxilla, the hard palate, the soft palate, and the submucous cleft. So if we consider these 9 parameters, and if they form a Y, you keep shading what is affected. So this is for all of us to be on the same platform, rather than using complicated and multiple terms. We use shading of this Y, and that's what we call as the Kernahan's classification. Now, coming to the basic guidelines there, the ISWOC has given us an excellent basic training on the 20+2 planes approach on which we base our anomaly scan. And the minimal evaluation of the fetal face should include an attempt to visualize the upper lip for a possible cleft anomaly. So this is the bare minimum that they expect us to do. They have not mentioned that the diagnosis of cleft palate is a bare minimum necessity on an antenatal anomaly scan. So cleft palate is not a part presently, but the guidelines keep changing as we realize the importance of including more things in our antenatal diagnosis approach, because it changes the immediate postnatal approach immediately. So when we come to the face, you need to look at the coronal view of the upper lip, nose and nostrils. You need to look at both the orbits, and you need to look at the profile. So coming to that. Okay, so the plane 18, it's kind of the face of the baby kissing the screen. That's how we explain to the couple. And you see the nostrils above here. You see an intact upper lip and an intact lower lip there. We need to make sure that there is enough amniotic fluid around this part of the orofacial part of the fetus to make sure you're not missing transverse clefts of the lip or a very tiny hairline crack in the lip, because you need to make sure there is enough amniotic fluid, and then you can visualize the nostrils and the upper lip properly. Coming to the plane 19, this is the orbital plane. Not relevant to the orofacial cleft, but these are the facial planes that are required for the basic evaluation of the fetal face according to the ISWOC guidelines. Now, this third plane, which is the plane 20, is a mid-sagittal facial profile where you can visualize the nasal bone, And it is extremely important that we use this plane for taking indirect hints for the cleft palate, and we will see how. So this is again an enlarged view of both the nostrils, the upper lip and the lower lip. And if you see, there is an anechoic space between the upper lip and the lower lip, and that is the amniotic fluid. So this is the ideal way to visualize. And the fetus often yawns, is swallowing amniotic fluid. So be opportunistic when you scan and make sure that you see this amniotic fluid between the upper lip and the lower lip, and that will give us the best chance for diagnosis. It's known as the nose, chin, lip view in very simple words. This is a fetus yawning, and the more amniotic fluid you have between the upper and the lower lip, the easier it is to visualize the intactness of the upper lip there. Now here we come to see there is a pathology. Yes, below the nostrils, you cannot see the entirety of the upper lip, and there are some, there is a breach in the upper lip, as you can see where the green arrows have been put there. So this is a cleft lip that you are visualizing. Now, when you visualize the nose, lip, chin view, you see the Cupid's bow. The Cupid's bow is the upper part of the lip that forms a Cupid arrow kind of a thing. And if that is disrupted, you should red flag this scan and try to look further. Okay, so here you see in the 3D below that the Cupid is disturbed, and that's because of all these clefts happening. The extreme left shows a unilateral cleft lip there. The middle one is showing the median cleft lip. So this is a midline defect where you have the upper lip divided into two parts by a midline gap, and that's a median cleft lip. And there is a bilateral cleft lip where the upper lip is divided into three different parts, three different soft tissues. It is the median and the bilateral cleft lip where you look harder for presence of cleft palate. For associated abnormalities, you go back to her first trimester screening and make sure that the aneuploidy risk was low, because we are aware that cleft lip palate can be a part of trisomy 13, 18 as well. So how do you diagnose a unilateral cleft lip? There is a lateral defect partitioning the soft tissue into two different parts, two different unequal parts. There is asymmetry of nose. Now, if you just observe this right image here, the one side of the nose is dipping down into the cavity, into the defect, and that is a nose falling sign. When you the nostrils are not at the same level, and when you see that one is below is dipping down, because when there is support from the philtrum, there is no support from the upper lip, and hence that part of the nose will dip down, and this is known as the nose falling sign that you can see in the image on the right side. There is stretching of the ala nasal, and the extent of the midline may or may not involve the philtrum, which we should always mention on the antenatal report, because such couples are then going to go to our colleagues, to our orofacial surgeons, who need this information to prognosticate the fetal situation postnatally and plan surgeries accordingly. Okay, so now, yeah, coming to the bilateral cleft lip, you see it's very evident even on the side profile. There is a middle tissue, excess tissue, which is actually a premaxillary protrusion. So imagine there is a bilateral cleft and the middle part of the tissue is just protruding out. So even a midline facial profile will give us an idea of the protruding premaxillary area, and that hints us towards looking for bilateral cleft lip. So two clefts on either side of the median process, the upper lip divided into three parts, the right, the left, and the middle, and two breaches that you see as anechoic parts, which is a bilateral cleft. Okay, like I already mentioned, that is very important to see that. So on the right side, you see a very, very thin hairline cleft lip. And unless you have a good amniotic fluid, you would not have been able to diagnose this little cleft lip. And in opposition to the cleft palate, which would be more disastrous as a diagnosis, cleft lip is something that the parents immediately see when the baby is born. So it's catastrophic if you don't prepare them antenatally, if you have not done a prenatal diagnosis, and suddenly the baby is born, they are just sitting there with all expectations of good news, and the baby is there in front of them, suddenly with this crack on the lip, it's a big deal for them right there and then. So please ensure there is enough amniotic fluid, and that helps in diagnosing these. Now, what is the difference between bilateral and median? It's very evident on the left side that the upper lip is divided into 3 parts. You have a prominent medial process, a premaxillary process there with bilateral clefting. On the other side, there is no median process and the middle part is missing, and the upper lip is divided into 2 parts with a missing middle part. This is the difference between a bilateral cleft lip and a median cleft lip there. Okay, so is there really a need, once you have all your guidelines in place where legally you are safe if you just diagnose cleft lip, do we really need to go in for an extended facial sonogram and look for cleft palate? Yes, we do. And that's because the whole problem is the cleft palate. The lip is more easily repairable, is associated with less problems. And when you look for an orofacial cleft, when you find a cleft lip, you got to look harder because there are many more problems that would surface up when you look harder in this baby. What is the importance of diagnosing isolated cleft palate? Now, once a cleft lip is detected, it's usually an extended evaluation and you go in and diagnose a cleft palate. That's much more easier. But if there is a previous child or there's a family history of cleft lip or cleft palate, the recurrence risk is a major concern. It could be as high as 15 to 45%, depending on how many individuals are affected, whether it is cleft lip or cleft palate or both that are seen in the parents or in the previous sibling. Now, more than 100 micro deletions and duplications are associated with isolated cleft palate. More than 400 syndromes are associated with isolated cleft palate, and isolated cleft palate is very, very highly likely to be associated with other problems like extrafacial problems in up to 80% of the babies, and therefore it is extremely important that we diagnose a cleft palate. Now, why is there such a low detection rate of cleft palate? If you just see here, if you see the mid-profile ultrasound picture, you see, is my pointer visible?
Yes, ma'am.
Okay, so you can see that you can imagine the maxilla there, but there is a shadowing because of the maxilla, and you cannot visualize the posterior part. What is below the maxilla? Is this line really an intact palate, or is it the vermin bone, or what? So we are not able to visualize, and that is because of the technical difficulties in the shadowing, in the acoustic shadowing in the premaxillary area. So acoustic shadowing hinders the visualization of the maxillary line, and therefore ultrasound evaluation of the fetal palate that is isolated. This is the main catch where we need to improvise on our detection rates. And how do we do that? Yes, sorry. So there was an excellent paper that came by. I'd mentioned Dr. Lakshmi there. It is an absent superimposed sign, which is a novel marker for early diagnosis of cleft of secondary palate, which was actually really being missed in a lot of times. So a normal superimposed line is to be documented to make sure that there is no cleft of the palate. Now let's see what this superimposed sign is. If you see all these images, it's not just the one line that you're seeing as the maxillary line. It is 2 split lines. It's a bifid line. And what is this bifid line? It is the vomeromaxillary junction. So it is the vomer bone and it is the maxilla, both that you need to document to make sure that there is no cleft of the secondary palate. And based on a simple anatomical fact that if the palate is absent, the maxillary line is formed only by the vomer bone. We'll just see in the images to come, and it appears as a single line, and then you won't be able to see the bifid line that you were able to see on the previous images. There would be no superimposed sign, and it is better appreciated as early as 12 weeks. So where we are moving towards the inversion of antenatal pyramid of care, we want to make more diagnosis at 12 weeks than at 20 and 28 weeks. So a simple mid-sagittal view, which we are already using for the NT and the NB at 12 weeks, please also document this bifid line, which is the vomeromaxial line. Now let's see what it actually is. This is a video where clearly you can make out that there is a single line here in the second half of the video. And if I go back, there is a proper bifid line here where you can see the vomer individually and the maxilla individually. Whereas here you see a single line. So then you have to make sure that you document this, because this baby is highly likely to have a cleft palate. In fact, you can even see that the baby has a cleft lip, a bilateral cleft lip, because you can see the premaxillary protrusion here if you just observe. So this on the left is a normal superimposed sign where there is a bifid area. On the right, there is a single line, which is actually not the palate, which is actually not the maxilla. It is the vomer that you are mistaking as the palate, and you are missing this cleft palate here. So this yellow line is the premaxilla, the green is the secondary palate, and the second wing of the bifid is actually the nasal septum or the vomer. So this is what you need to take an effort to visualize. Okay, unfortunately, you don't have to take an extra view for it. This is the same view that you're using for your nasal bone and nuchal translucency, where you can just pay a bit more attention to this bifid approach and diagnose a secondary palate cleft. Now, another thing that you can do is visualization of the uvula, and how you can do that from a biparietal diameter plane. When you're taking the BPD plane, just keep going caudally, and on the right side you can see this equal to sign. This equal to sign is the uvula, and the presence of a uvula is a surrogate marker for the presence of an intact secondary palate. So these are all indirect signs that help us to diagnose palate abnormalities. Now, as early as 12 weeks, this is a premaxillary view, where you see that there are nasal bones, the two nasal bones on the top, which is number 3 there. The frontal process of maxilla is the number 1, which you can see very well intact. And the number 2 there is the primary palate. Okay, so if you see there is an intact primary palate in this simple premaxillary view, you have ensured an intact palate. So this is another indirect way. So a new sign that has come in around almost 5 years back actually is the maxillary gap sign. And this is also going to be very helpful for us, because this is the same view you're using for your NT and NB. And on the left, you see there is an intact maxilla, whereas on the right, you see there is a breach in that line there. Okay, so it's a very simple view. If you go back to your images, if you've missed a palate and you go back to your NT scan images, you will find there was a breach in the premaxillary area, and this would help us in diagnosing cleft palates. So this is how the breach looks there. In this, the first one is normal, whereas all others are showing breach in the maxillary line there. So coming to the last 2 slides, this is the simple algorithmic approach that we need to follow. And you need to make sure if the cleft is unilateral, bilateral, or median. So all of you here who are hearing, who are going to scan and report a cleft lip and or a cleft palate, you need to mention all of this on your report. Just mentioning that there is a cleft lip and a cleft palate does not suffice, because the whole counseling, which is going to be done by our oromaxillary facial surgeons, and in fact the plan that they're going to put in mind of the couple for postnatal diagnosis will depend on all of this. Okay, so whether it is unilateral, bilateral, or median, whether on the actual view in the alveolar arch, is there an isolated cleft lip, or is there a cleft lip plus palate, or is it an isolated cleft palate? Have you seen the associated abnormalities? In the premaxillary triangle view, is the cleft confined to the premaxilla, or is it extending into the secondary palate? Because this is going to be one of a very important prognosticating factor by our surgeon colleagues to counsel the couple. What do you do next once you diagnose an abnormality? You look for more. That's the first thing you do. Okay. So when you diagnose a cleft lip and palate, you don't stop there, because probably the decision of the couple, whether they would want to continue the pregnancy or not, how the prognosis is, will depend. Is there a VSD? Is there an aortic arch abnormality? Is there something in the brain that's going wrong? Does the baby have clenched fists? Have you looked for aneuploidies? So yes, that brings us to the next investigation. You have to offer them amniocentesis, and microarray is what needs to be done. Because it has been found that doing a microarray will diagnose 10 to 11% more abnormalities than a karyotype. So if you're any which way putting in a needle, please go in and do a microarray rather than going in and doing just a karyotype. The couple could refuse an invasive testing, but make sure you offer them and you make them aware that this is one of the things you could do to put your baby into an isolated cleft lip and palate. Mind well, isolated is the most difficult thing to do, because then the whole onus of responsibility lies on you to make sure the heart is fine, the brain is fine, the karyotype is fine, the microarray is normal. Only then are you calling this baby as isolated cleft lip and palate baby. Of course, there is a multidisciplinary approach. You don't do all of this counseling yourself. Inform the neonatologist. Make sure the baby is being born in a tertiary care setup. Make sure the surgeons are a part, the orofacial surgeons are a part of the team when this has been diagnosed. And of course, you need to follow up, because there would be, there is a high chance that there would be polyhydramnios, and you may see evolving defects on further scans, and that needs to be taken care of. So that brings me to the last part of my talk. Never be ashamed of a scar. It simply means that you were stronger than whatever tried to hurt you. So it's not possible. India is yet to reach a time where we can prevent all facial clefts. Soon, probably we are moving towards that with all the suggestions and what Ameya sir has put up. But I leave you with a thought that let's at least try to counsel and convince this couple to go in and meet a orofacial surgeon before they take a decision of, terminating the pregnancy at the drop of a hat, because we will soon hear from Dr. Ramamurthy sir how well these babies can be tackled once they have been told that they are isolated. Thank you so much for the patient hearing. Thank you.
Thank you, Pooja, for that excellent and highly enlightening talk. I think the more images I see of your scans, it makes me believe that we are reaching the final frontier, that we will be able to ensure that every baby born is without a structurally detectable defect. Thank you so much. I now move on to the next speaker for the day, and it is none other than Dr. Ramamurthy. Dr. Ramamurthy is the former president of the Indian Society of Cleft Lip and Palate and Craniofacial Anomalies. He is the vice president of the International Board of Certification of Specialists in Oral and Maxillofacial Surgery, and the former president of the Association of Oral and Maxillofacial Surgeons of India. He is the project director and consultant at the Smile Train project at the Bhagwan Mahavir Jain Hospital, Bangalore, and he's also associated as professor of maxillofacial surgery and program director in the fellowship Cleft Lip, Cleft Palate Deformities program at the Bangalore Institute of Dental Sciences, the Rajiv Gandhi University of Health Sciences, Bangalore. He's been a professor at the Division of the Maxillofacial Surgeries at the University of Cincinnati, Ohio, USA. More importantly, besides being an authority on the subject of cleft lip and cleft palate, he's extremely humble, extremely helpful, and extremely humane. And his passion for this problem and overcoming it is really boundless. And so we want to hear from him how this problem can be corrected what are the challenges, and what is the best prognosis we can offer to these children. Over to you, Dr. Krishnamurthy.
Thank you, Dr. Purandare. Thank you very much for that very kind words. At the very outset, as I get my slides on, at the very outset, I would like to emphasize how important this collaboration between Foxy and Smile Train has been. We talk a lot about teamwork. Oftentimes, it's a lot of lip service that is being given about teamwork. But this collaboration, which has been brewing for quite some time, has come to fruition today in this first webinar. And I think it's a wonderful opportunity for both fetal medicine specialists and those people who manage cleft lip and palate deformities to come together on a single platform and working together help make the burden for parents who unfortunately have to deal with this problem when their baby is born. If not anything else, I have benefited immensely from attending this webinar, listening to Dr. Lodha, looking at her slides. It was an immense education because we often see, in fact, even today, I saw a 1-month-old baby come into our clinic who was diagnosed with a unilateral cleft lip and palate at an anomaly scan done in the second trimester. And I was looking at the ultrasound images and they just look like shadows to me. I must thank Dr. Lodha, and I must thank myself for being here for this wonderful opportunity given to understand how it might be becoming much easier, much more scientific to diagnose this in an ultrasound scan, particularly the cleft palate. Many thanks, Dr. Lodha. So what I'm going to do in today's talk is not to discuss in great detail about management issues. Some of these things have already been highlighted. A cleft of the lip and or palate is a varied beast. The phenotypical manifestations are very varied. So are the genetic problems as well, of which we haven't understood enough. What I'm going to talk to you about is clinical presentation as opposed to what you would see on an ultrasound. I understand that I'm speaking mostly to people, members of Foxy and many of your fetal medicine specialists who will be carrying out routine ultrasound scans on a pregnant mother. And like I said, those shadows were such a strange thing for me, hypoecogenic and dots and black and white figures, which is very difficult to decipher for us. Similarly, it might be useful for you all when you meet a parent whose baby is likely to be born with this. It will be very useful for you to also have a mental picture of how these may present in life and what kind of issues the parents might face. So Dr. Pooja earlier very clearly mentioned about unilateral, bilateral, and midline cleft of the lip. I must say that the ones in the midline, the median clefts are extremely rare. And it's good it is so, because when you find these midline clefts, you find that they are usually a part of a group of what we call as a mid-facial, mid-craniofacial dysgenesis. So the problems here might include those structures of the midline of the brain, etc. And the patient's problems might be much more severe or significant as compared to the lateral clefts, either whether it is unilateral or bilateral. You can also see cleft palates again without a cleft lip. As you see in these pictures, you can see the complete cleft of the palate. What you see inside the mouth is the nasal cavity. There was a very good illustration of how it might see on an ultrasound, where when you have a cleft palate, you are only seeing the vomer. So in the first slide there in the middle, you see the vomer. which is not coming down and uniting with the palatine shelves. You can also get what we call as the subsurface or the submucosal clefts, where when you open the mouth and look at the child, there doesn't appear to be a defect. It appears to be intact. The signs are subtle, and these are the so-called submucous cleft palates, which are very frequently missed even by professional pediatricians who regularly look into the child's mouth on birth, and those who screen for congenital anomalies, because this particular palate might appear intact. I don't know whether there would be an easier way of diagnosing it in ultrasound. Most of them have bifid uvulas, and therefore I would believe that, as has been mentioned, that absence of an intact uvula itself is an indirect or a circumstantial evidence for a cleft palate. So clinically, if you see these submucous cleft palates, you might think that they're intact, but they might have a bifid uvula. You also see that the middle, or the area where the two halves of the soft palate meet, is quite translucent. So what happens in these defects is that the mucosal continuity is there, but the muscular continuity is not there, and therefore the midline of the palate appears thin and translucent. And to make matters worse, there is also what is called as the occult submucous cleft, where you may not see this translucency, where everything appears normal, but when the baby starts speaking, this baby will have what is typically manifesting of a cleft palate speech. So these are the various modifications, variations that you could see the presentation of this cleft lip and palate. And what we saw in the previous slides were isolated cleft of the lip, isolated cleft of the palate. Dr. Lodha gave us the numbers, but oftentimes, in about 50% of the cases, there may be a cleft of the lip and palate, and it could be unilateral or bilateral. You see in the bilateral cleft palate that the vomerine bone is in the midline. It's not uniting with either of the palatal shelves, whereas on the unilateral cleft lip, the vomer will come and unite with the side that is not clefted, which is what we call the non-cleft side, right? So classifications that you use, the Kerner-Herms classification is a very adequate, very meaningful classification. This is another slide to show that there was a classification much simpler than that, which was useful for the surgeons that came out of India. Now, talking about the incidence, both the previous speakers have spoken about that. The numbers slightly vary from one presentation to another, but they're all within the same range. Just to give you a little bit background of what's happening in this country, in India. Years ago, if you go back about a couple of decades to the beginning of the 21st century, it was found on extensive surveys that of all these 35,000 children that were being born every year with a cleft of the lip and palate, only about 25% of them were receiving any treatment. The management aspect has already been alluded to. It involves multiple surgeries and other adjunctive therapies, which includes management of speech, management of the dentition, the psychosocial aspects of care, etc., etc. But it was found that at the beginning of the 21st century, only about 25% of children born with the cleft of the lip and palate were getting any treatment. Most of these 25% did not receive comprehensive care. It was piecemeal, but the 75%, that is almost about 25,000 children every year, were not receiving any treatment at all. The game changer as far as management of cleft lip and palate in this country and many low and middle income countries of the world came with an organization called SmileTrain. I heard with great interest what your president was talking about, his concept of equity, his concept of ekikaran, and so on. It's extremely important that irrespective of whether you have the financial resources, whether you have the education, whether you have the wherewithal to approach for these complex treatment, you should get it. That is what the principle of equity is. And with a master stroke of a thought process of allowing local partners to be empowered to treat these children providing local hospitals around the low and middle income countries, providing them with financial and other resources to treat these children. An organization called Smile Train became a game changer, and in the last 2 decades has sponsored comprehensive cleft care. Simply talking about numbers, Smile Train has been able to support more than 2 million surgeries worldwide, and out of which more than 30% has been in this country. Today, you go to any nook and corner of India, there is a center that is available for taking care of these children. There are many other charities that have followed suit, and the burden of care has been taken off the shoulders of the parents virtually. But I'm not going to discuss in great detail about the various aspects of management of cleft lip and palate deformities. I believe this is a series of webinars that we are going to have to sensitize each other, like how I got sensitized just listening to Dr. Lodha. I believe that there will be opportunities for me to speak in a little more detail about the management of these deformities. But there is one single important thing that we need to talk about, something that in my experience that does not happen quite as often in our country post the diagnosis on an ultrasound scan, that is antenatal counseling. I think Dr. Pooja spoke about it. She said to us that it's such an important thing that here are a couple awaiting the most joyous moments of their lives in getting a baby, and then they realize that the baby is not going to be normal. That can be devastating. It can have serious consequences. And if at that point of time when this diagnosis has been made and this beans has been spilled, if there is adequate support not available for this couple, it can be very disastrous. So here is a paper that looks at the pros and cons of antenatal counseling. Obviously, there is a con, simply because they come to know of it many months before the baby is born. This is something that has been held against it, you know. And also we have spoken about the issue of increased tendency to terminate pregnancy. But look at the various advantages that has been listed for doing a good antenatal counseling. It prepares the parents. Time and again, when we see these parents, they come with a significant degree of angst, anxiety, tension, and they sit down and they talk as they absorb the details, and as they find out that these are particularly the isolated cleft palates, isolated cleft lip and palate, as Pooja mentioned, are conditions which are not so significant in terms of affecting quality of life of these children as they interact with the team that manages these problems, as they sit and look at the results that can be achieved. In other words, parental education goes a long way in making the parents prepared. So this is something that is no longer a shock when the baby is born. They know what needs to be done, particularly from a feeding point of view. This is one of the problems that we have when a child has cleft of the palate. Breastfeeding is almost impossible. Not that it is virtually impossible, but it is very, very unlikely that the mother will be able to do adequate breastfeeding when the baby has a cleft of the palate. So it is extremely important that you don't waste time, that you don't allow the child to starve. Sometimes they come in a stage of marasmus when mother hasn't been educated. So it's extremely important that this education, this preparedness is something that we can achieve by doing this antenatal counseling. There is a very important paper that has come out of the US. Arun Gosain, one of the plastic surgeons in the US, did this study, and he found that these kind of early education preparation leads to high degree of satisfaction with multidisciplinary care. And as far as the United States, from where this data comes in, pregnancy termination for isolated clefting appears to be an uncommon event. I was earlier talking to Professor Patel, and I mentioned that in Australia, I've heard that the termination rates are high, but this paper indicates that in the US and in many other parts of the world, if you have adequate antenatal counseling post the diagnosis, the termination of pregnancy particularly in the so-called isolated clefting is not so common. So by doing this counseling to a significant extent, you can bring down the rates of termination, particularly that which may occur during isolated clefting. This is another interesting study that came out. This is the reason why we are here today. This is the reason why it is important for you and us to join together. You are the people who see the parents. You are the people who do the scan and possibly give the bad news, as it were, to the parents. But at that point of time, where do you provide the counseling from is extremely important. And this is a paper way back in 1998. It shed a lot of light on this, that in this study, only 1/3 of the families felt they had been given adequate information from their obstetrician or ultrasonographer. All who had prenatal contact with the cleft field team felt it was valuable. There are a number of studies that show that it is possible that the fetal medicine specialist has inadequate information regarding what comes next after the baby is born. It is possible that they are very busy and they're not able to provide that support. And therefore, it is very important that we link up very quickly and follow a regular referral system where once this diagnosis is made, they are referred to the nearest multidisciplinary comprehensive cleft care center, where one or more of the team members will sit down with these parents and sensitize them, prepare them, educate them, and make sure that once their baby is born, their life can be as joyous as it would have been if the baby was not born with a cleft. So very quickly, what do we do at antenatal counseling? One of the things which has already been mentioned, this is something that you might have already done. Look for syndromic association. Once again, Dr. Lodha very strongly emphasized the things that you need to do once you diagnose cleft lip and palate. And then once you've done that, you know that this is an isolated cleft lip and palate. Most important thing is to present the facts and figures. Tell them what is good about this, what is not good about it, what follows, and what is going to be the prognosis. Also, explain to them what to do at birth. Like I mentioned, the single most important problem that faces the parents is how to feed the baby. And that is something that can be very easily taken care of if this has been discussed. Protocols can be very daunting because these children require multiple surgeries. They will require speech assessment and therapy. They will require treatment for their teeth and their jaws in the form of orthodontic braces. They might need support from a psychologist, a geneticist, etc. So outlining the protocol, keeping it simple, explaining to the parents that it is not their problem, it's a problem that is being transferred to the cleft team, which henceforth will be responsible for making sure that their baby is taken care of, is extremely important. And what is very important also in this light is not to overwhelm them with detail. Provide a sketch, an overview, not the gory details of what might follow. Right. Very quickly, to end my talk, like I said, I will not be dealing with the details of the management. That will be for another webinar. But to suffice to say, for all those parents, for all those fetal medicine specialists who believe that their advice to their parents has to be terminate, because this is something that happens. I do remember talking to the Karnataka state fetal medicine specialist many years ago, and a number of them came and told me later, this was about 15 years ago, they came and told me that we were not aware that these children can lead a normal life. There is a tendency when you are not sure what kind of a future awaits these children, there is a tendency for you being sympathetic to the parents and then advocating a termination. So for all those people, be it parents or clinicians who think that, particularly in case of isolated cleft of the lip and palate, termination is an option, I just want you to see some of these pictures. These children whether they're born with unilateral or bilateral, whether they're minor or significant defect, can be treated. They can be made to look normal. They can be made to function normal, and make them lead productive lives like would any other child that is born without any congenital anomalies. Thank you very much for your time.
Thank you so much, Dr. Krishnamurthy. Thank you. Thank you all the speakers, Dr. Amaya and Dr. Pooja, for such an enlightening session. I mean, this being the first in the series, this webinar is a learning for all of us. And I would request the audience that they can, reach out to us. We are open to take all your valuable feedbacks and even these suggestions on topics. And, on behalf of all the audience, the Foxy, Smile Train India, I would request all our distinguished speakers to please accept our sincere appreciation for the outstanding and the informative session that was today. Thank you. Thank you so much.
Yeah, Charvi, there are a couple of questions for our experts. So I've filtered them to just one question each for both of them. We'll start with Pooja. Pooja, Dr. Ashwini Rathod from Pune has asked this question. Is Pooja there?
Yes, sir, I'm here. I'm here, sir.
So the question is, if a patient is diagnosed with cleft palate in the NT scan only, whether to go for NIPT and early anomaly scan or early anomaly and amniocentesis for confirmation of certain genetic disorders. So basically, she wants to say at NT scan, a high suspicion or a diagnosis of cleft palate, what's the next approach?
Okay, so thank you, sir. Thank you, Dr. Ashwini, for this question, because this is a very common scenario. We are all now overexcited about the NT scan, and the moment we find something not right on the 12-week scan, we should not jump to conclusions, because eventually the fetus is only 6 centimeters long. So we need to confirm the diagnosis, especially the one like an isolated cleft palate, because it could be really subtle at 12 weeks, confirm it at 16 weeks. And when you do so, NIPT is definitely not a good choice of the test. NIPT is an excellent screening test for Down syndrome. And cleft palate and cleft lip are problems which are more likely to be with trisomy 13, 18, microdeletions, duplications, and genetic syndromes. So doing an NIPT, you would end up spending the couple's money, being falsely reassured with a low risk, and still ending up with a baby with either another aneuploidy or a genetic syndrome. So the correct approach would be call her back mention your doubt on the NT scan, call her back at 16 to 17 weeks. If you confirm the diagnosis as cleft palate, do an amniocentesis, do a microarray, and do a thorough scan repeated at 22 weeks, and then call it isolated cleft palate.
Okay. So I think that's very well guided, Pooja. We falsely believe that NIPT is the magic bullet for the magic tablet for any genetic or chromosomal issue, but I think it has its own limitations as well. So yes, the question is to you, Dr. Ramamurthy. In your vast experience, what do you feel is the most important factor that will improve the quality of life of the children post cleft lip surgery? This is from Dr. Monica Dev from Tamil Nadu.
Right. Thank you very much. If we are talking about somebody who's got a cleft of the palate, the single most important thing that will improve quality of life is getting normal speech. This is holy grail still. Even when we operate at the right time, somebody who's well experienced does it, you can still have a small percentage of children not being able to speak normally after surgery. They might require additional intervention in the form of speech therapy, occasionally a second surgery as well. So as far as quality of care is concerned, improved normal life is concerned, getting back normal speech after cleft palate is the single most important outcome that we are looking for.
Yeah, so I think that's a very well made point. just for the benefit of our viewers, and you will agree with me that the challenges that we see as physicians, especially in these patients, are the challenges with respect to nutrition, with respect to phonesis, with respect to swallowing, with respect to respiration and breathing, and last but not the least, the cosmetic issues and the psychosocial issues associated with that. So I think as physicians, we need to look at both like you rightly said, speech sort of positively enforces normalcy in the human beings in the human being's mindset, but also we must keep in mind that nutrition, respiration, deglutition, and the cosmesis are also kept in mind. So I think it's just not one parameter, but I frankly feel that it is all the other parameters as well. Last but not the least, Pooja mentioned that many a child are affected with a syndrome, which could have other affections as well. So even developmental milestones, scholastic performances, etc., have to be taken in stride as well. So while deciding the optimal outcome or a favorable prognosis.
Can't agree with you more, Dr. Purandare. I couldn't have put it any better. I agree with you. It's a multifaceted issue, starting from nutrition from the time the baby is born till he or she gets a job after finishing college. I agree with you.
Yeah. So I leave you with a few concluding remarks. I think cleft lip is a defect that is very much a reality. It may be in isolation or it may be with palate. Better diagnosis is now possible with the best of technology as far as imaging is concerned, but we need to have a correct approach and at times think beyond the cleft to other syndromes as well. And once the child is born, you need to counsel the parents about the realistic expectations, motivate them to remain compliant through the course of surgery, and then expect the best of outcomes. Last but not the least, it is still a dream, but it will turn into a reality if every obstetrician emphasizes the importance of nutrition, of multivitamins, especially in the periconceptual period. We will see lesser and lesser cleft palate and cleft lip and offer better and better outcomes then to these babies. So thank you once again. Let's end with a big smile on everybody's face. Pooja's already got a DP with a big smile.
Yes, she has.
I think
I'm driving. I'm sorry, sir. Ameya sir, very, very nicely and very aptly put up concluding remarks. And Ramamurthy sir, thank you so much for your inputs. It's been a learning experience for me as well. Thank you very much, sir.
Thank you, Pooja.
And I hope that this Smile Train project continues more and more. It becomes more accessible, more affordable, people are more aware about it, and Foxy and all the other partners collaborate year after year in a much more stronger and amplified manner. So thank you once again till we meet in the series. Thank you.
Dr. Purandare, can I have one last word?
Sure.
Yeah, so I've been called Ramamurthy a number of times. My name is Krishnamurthy. I believe it's a Freudian slip. I believe it's a Freudian slip because the best fetal medicine specialist that I know in my city is Dr. Ramamurthy.
Yeah.
Okay.
Sir, I think we are just in the post Ram Navami phase. And
that's possible. But Dr. Ramamurthy in Bangalore is the best fetal medicine specialist.
Yes, sir is an icon.
They wait for months together to get an appointment with him. So sometimes I call up and say, sir, can you please see this patient quickly?
Yeah. Nevertheless, Ram fought over the evil and Krishna guided Arjuna to the path of success and the path of dharma and karma. So I think Krishnamurthy will do that for the babies.
Thank you. Thank you very much.
Ameya sir has his way with words beautifully. Thank you so much for saving me, Ameya sir.
And all this will be done by the divine intervention of Pooja Okay, because you know that when you do puja, you get blessings.
Absolutely.
That's
Absolutely.
beautiful. Thank you. Thank you so much.
Thank you very much.